Hello, this is John Canalopoulos from our center here in Athens, Greece, the LaserVision Ambulatory Surgery Center. A very, very interesting patient. We're going to see the surgery uncut times 4 speed. You can see the small pupil. The peculiarity of this patient, she has chronic uveitis, a very, very dense cataract. Her vision, believe it or not, this is her only eye, is bare light perception. She has to be carried around, and she's in her early 60s. This lady is 62 years old. Everybody told her up to now never have cataract surgery, and of course she followed advice. I'm going in with epinephrine to see if I can dilate the pupil. I release the posterior syncytiae. I'm going to put air and use, of course, blue to stain the anterior capsule, viscoat to remove the blue and protect, of course, the endothelium. I'm using my Kuglen hooks to stretch the pupil, and the picture immediately has improved drastically. You can see that the cataract is relatively dense. It's a brown, dense cataract, and I'm still contemplating whether this will be an extra cap or a phaco procedure. By the way, the patient has almost 6 diopters of width of rule astigmatism, so using a toric lens at this point is kind of a dream, a very unlike dream. You can see how with the uveitis and this very dense lens that may have reached the Morgagnian level, the capsule almost looks shrunk. The blue helps make the anterior capsule more firm, and I'm able, and the key of the whole procedure, I think, was that last capsulorhexis extension that enabled me with hydrodissection to pop the lens in the anterior chamber. So now you can see a very dense lens in the anterior chamber. I'm going to pre-chop the lens with my Kuglen and my Sinskey hook. I'm already starting to get an adrenaline rush. I'm doing also a pre-chop of the 2 hemimeridians of the lens, more viscoat here to protect the endothelium as much as possible. Again, my Kuglen, my Sinskey hook. Um, very honored to have met Bob Sinskey back in the day and all his contributions to the evolution of phaco, and of course my favorite second instrument and procedure, the Sinskey hook. So I'm going in with 100% phaco power, our signature device, and now the procedure starts to become a feasible, difficult but feasible phaco procedure. We ended up using just 200 joules of energy in this case, which almost seems a great surprise. More viscoat I'm on my second tube, and we can see that this indeed became possible. A brown, very dense cataract completed with phacoemulsification, and we're at the final stages. I decided to leave this case unedited. I apologize of some of it being outside the range of the microscope. We can also see that the posterior capsule has a very dense, thick, scarred area. Almost looks like a plaque, which was probably a result of all the uveitic episodes that this patient had. I'm using viscoelastic to remove all the large pieces of residual nucleoli, pieces of the nucleus. And I'm at this point where I'm going to do removal of the cortex, and I'm realizing that the capsule bag is not bad. So visual rehabilitation for this patient, in my mind, is starting to include, and you guessed it, a toric intraocular lens. So we're going to really think out of the box here, and we're going to convert this almost automatic extracapsular surgery to, why not, a toric intraocular lens that after the, as we can predict, the necessary capsulorhexis that will perform, it'll be an easy one because this scar is eccentric. I'm checking with my Kuglen hook to make sure there's no vitreous anywhere, methylcellulose to bloat the capsule bag, and we're going back to the um, Acrysof toric IOL calculator. The keratometry is here. I knew I kept notes for this video. 4733, 4094. So we're looking at almost 6 diopters with the rule of astigmatism. So we're using our plus 13 adapter lens. This eye was a very high myopic eye, but at T9 with 6 diopters of astigmatism, this is a max lens we can use. And sure enough, the Halloween story turns into a more of a happy ending fairy tale story. Um, I'm putting my lens in. Of course, you can imagine that the size of the lens that we removed was gigantic. So the capsule bag seems to be a couple size bigger than normal. I removed those synechiate tags from the pupil, and I'm placing in my toric lens. I'm going to use the 6 o'clock mark that we added as a guide for this. The case is completed. We used the sodium chloride ointment the first days. I'm using my IOL angle to make sure that the lens is sitting in place. I'm doing my final adjustments, making sure my incisions are watertight, and they are. We also started the patient on 3 Medrol pills of 16 milligrams a day, so close to 1 milligram per kilogram a day prophylactic treatment for a week, converted by her uveitis specialist to 2 a day for 5 days, and further tapering. We'll see the patient at 1 week time. Her vision has jumped to a remarkable 20/80 despite this very dense scar on the posterior capsule. It's almost a thick plaque. So here's the patient at week 1. We can see that they were able to take this very dense lens out and preserve the cornea. And I thought you found this interesting. Happy to share it with you. This is John Calapos signing out.